Do you think that in 10 years, a majority of people, including adolescents, will be on GLP-1 medication?
Yes, and I predict that in the next 2 generations, type 2 diabetes is going to decrease. We're going to have less incidence of certain cancers that are associated with obesity, such as postmenopausal breast cancer, colon cancer, prostate, thyroid, pancreas. I predict that we're going to have less chronic diseases, that specialties that were built around the chronic complications of obesity are going to disappear, and we're going to be pretty much focused at the prevention part with the GLP-1. Again, that's probably not going to happen in 10 years, but maybe in the next 2 generations, right, we will see that.
Welcome to another episode of the Save Yourself podcast. I'm Dr. Amy Shah, and I'm here, honestly, to help you find your gifts. And why do I say I want to help you find your gifts? Because I think society tells us that we're on the decline. And I'm here to tell you that there's so many things that you can get better at. Your memory can get better. Certain parts of your brain can get stronger. Your immune system, your gut, your muscles, your bones. I mean, there's infinite amount of things that you can actually work on so that this part of your life is the best part of your life. I am very excited to talk to a doctor today who is one of the kind of foremost women's health specialists when it comes to GLP-1 medications, your Ozempics and Mounjaro and all Wegovy. And we're really going to dive deep and answer your questions. I think there's a lot of misinformation out there and there's a lot of chatter and controversy. So I was so happy to have her on so that you can kind of get the real truth. Now, remember that this podcast is for you. It's so that we can dive deeper into some of the topics that I know that you're wondering about or that can be actionable and helpful to your life. So if you find it helpful, I would love for you to subscribe or leave a comment. That actually makes a huge difference. As you know, I don't do a ton of ads on the podcast, and I don't do a ton of ads in general. I turn down a lot of stuff because I really want to keep this educational as much as possible, although there are some things that I love and that I have partnered with, but I sprinkle it in as little as possible so that you can just get straight up content. And even when I do the partnerships, I try to make it science first. You'll notice I'm always trying to give you value. It's always a balance. And so I hope you enjoy this episode. I'm going to introduce her really quickly. Dr. Rocio Salas-Whalen is a board-certified endocrinologist and obesity medicine specialist. She is actually widely recognized as one of the early adopters of the GLP-1 therapies in the United States. She has 15 years of experience. She actually has an upcoming book called Weightless. It's like a new guide for the GLP-1 medications designed to support people before, during, and after weight loss therapy. It goes beyond medication. It actually addresses kind of like the physiological, social, cultural, and metabolic changes that patients face. In her practice, she has metabolic science with compassionate, individualized care. Her expertise spans perimenopause and menopause. She leads a menopause redo. And then she's also educating people all the time. She's founder of Strength MD and the Drive Revolution, things to help people with metabolic wellness, muscle health, and alcohol-free living. She's an immigrant from Mexico who came to the United States to pursue her dream of becoming a physician. She has a thriving practice in the Upper East Side of New York City, and she transforms lives and rewrites the future of women's health. So I'm very excited for you guys to meet her and for us to start this podcast. So let's get going. Welcome, Dr. Salas-Whalen. I just did your beautiful bio, and I'm so excited for everyone to get to know you because this is a hot topic right now.
Definitely. No, thank you so much for having me. And I think that these conversations can tend to be long because there's a lot of questions regarding it.
Right. So we go on the internet and we hear all the nonsense or the debates. What is the biggest misconception about these GLP-1 medications? Or maybe a couple.
There are many, but I would say one of the constant one that I see online or get asked about is how old are these medications? How well do we know them, right? What's going to happen in 20 years? Are there going to be side effects that we never heard about it, but because of the time, they're going to start to pop out. So patients are worrying of what's going to happen after. So they're not new drugs. They've been FDA approved for 20 years. The first in its kind was Byetta, which was Exenedin, and this was approved in 2005 for the treatment of type 2 diabetes. But as you know, any medication that gets approval by the FDA has almost a decade of being studied, this medication, right? It's the same with GLP-1. So we do have long-term safety data. The other myth or misconception is the easy way out, that people are taking the easy way out by using this medication and not doing it like the old school, which is exercising and watching what they eat. And that's something that I learned through my patients. I did not learn that in medical school, in my fellowship of endocrinology, or even in my obesity boards. It was something that I actually learned through my patients when I was seeing patients and they were coming to me telling me everything that they've been doing for many through decades, right? Struggling, doing diets, exercise program, trainers, wellness camps, fat camps. Some patients been on a diet since they're 10, since they're 12, and they're in their 50s and their 60s. So patients have been doing what we thought they needed to be doing, which is exercise more and eat less. But that's not the reason why some people may have obesity or have difficulty with weight loss, or easy to gain weight. So patients really have done their legwork to earn this medication.
What about the women in perimenopause and menopause? I think a lot of debate has happened online really about, what about women who aren't necessarily obese, but they have gained some weight in perimenopause or menopause?
Definitely, if somebody says, "Oh, I only have 5 pounds to lose or 10 pounds to get to my weight loss goal," I always like to ask if getting to that point, if losing 5 pounds, if losing 10 pounds, or even to maintain your weight, is it a full time job, right? If your life revolves around getting to those last 5 pounds, getting to those last 10 pounds, or maintaining your weight, then you definitely would benefit from the medication, because there's many reasons why you're struggling. It's not just that you're not exercising or you're not eating healthy, right? With the majority of women, they do. So I would say if it becomes a full-time job, then you are somebody that most definitely would benefit from this medication.
For people who are listening or watching, why is it that women in perimenopause really struggle with that weight gain?
So from up beyond 40 years old, once a woman turns 40, our life hormonally changes, professionally may change, family dynamics may change, right? So we get attacked by different settings and different points in that period of our life. Number one, the hormonal changes, right? Perimenopause. The period of hormonal chaos. Here, because of the fluctuations or drop of estrogen, our body composition changes. Estrogen keeps our body in the body fat more like in a fertile age, which is the hips, the breast. But through perimenopause and menopause, fat storage actually becomes central, abdominal, and for many intra-abdominal, meaning visceral fat. And I hear this all the time, patients telling me, this is not how I used to gain weight. This is now how I normally put weight on. It becomes more central. Also, due to the hormonal fluctuations, our lean muscle mass, it may be more difficult to maintain, easier to lose, and more difficult to gain, right? So we have that already hormonally affecting our body composition. And then we add children's stressors, maybe children, teenagers going to college, not sleeping well, our parents may be aging. And because of that, it becomes so much easier to gain weight in that period of life. And I see this many women that never struggled with weight, or what they did physically and nutritionally was enough to maintain a normal weight. But when they hit this period of their life, it's like everything else is not supporting for her to maintain that weight.
Yeah, this whole recomposition is such a big thing I see for myself and for patients, like feeling like you're gaining a lot around the midsection. And is there a reason why the body would start to shift that?
Because of the drop of estrogen, because we start to lose the amount of estrogen that we had in our fertile years, right? That kept our body composition in a more healthier metabolically way. So we know when postmenopausal women have a highest risk of developing type 2 diabetes, and it's because of that, because the change in our body composition, because that fat storage that were in the hips and in the breast goes intraviscerally, right? And that's what we call the bad fat that promotes insulin resistant hyperinsulinemia, chronic inflammation. That's also why there's increased risk of cardiovascular disease, also because of that chronic inflammation that we have if we have visceral fat.
I saw, and maybe you don't know the answer to this, but I saw some critics online saying that muscle loss doesn't actually accelerate during the menopausal transition. And that was very confusing to me because I really did think that with the loss of estrogen, it's difficult to make muscle, but you're also losing your lean muscle mass. Isn't that not true?
Definitely. So, muscle has estrogen receptors. There are estrogen receptors in muscle mass, also testosterone receptors, right? And those two hormones, they tend to decline as we hit midlife. So, it does, but I'm not saying that it cannot be changeable, or I'm not saying also you need estrogen and testosterone. It just means that you need to be lifting heavier and definitely keeping an eye on your nutrition. But also the changes that the quality of life changes so much in perimenopause that if you're not sleeping, you're not going to want to go to the gym. If you're not sleeping, you're not repairing muscle to grow. Muscle grows when you sleep. So if you're not sleeping, you're not going to have the energy, you're not going to have the mood to maybe lead a healthy lifestyle too.
I'm glad you mentioned that because I myself have always had sleep issues, especially around my period. And so when perimenopause hit, that was like the first sign that I was in perimenopause. It's like my sleep just got worse and worse. And it used to just be that week before my period, the late luteal phase, and then it just got like stretched out from there. And yes, there was a lot of life changes that happened also. But I think that women, so many women kind of see that as one of the first signs of perimenopause. And it might not make a lot of sense because you're like, I went crazy trying to think, like, what am I doing wrong? And switching my sleep routine. And just knowing that it was perimenopause really helps me. Not that, that solved all the problems, but at least I could approach it in a different way than feeling just out of control.
I mean, if my patient is not sleeping, nothing that I do is going to resolve everything, right? So I always say if I have one symptom, if I had to pick one symptom that I can improve in my patients, is always sleep.
How do you feel about the removal of the black box warning on hormone therapy products? Like, what's your take on that? Because I know that's been a lot in the social media
Yeah.
right now.
Many physicians refuse to prescribe hormone replacement therapy, even to talk about it, or they shush away their patients because of the black box warning, right? So I feel that that is going to open the window for them, for any physician to really research the data, right? I'm not saying take it into account and just start prescribing hormones for everybody. No, we still have to make sure that we're giving it to the right candidate, to the right patient with the right medical history, but at least I feel like that's a block that is removed for some doctors. Now they're going to have to, there's no more excuses of the black box warning. So they're going to have to do their own research to see if it's something that they can recommend their patients, right? Because I think that was an excuse for many doctors because of that warning exists. They won't even dig into maybe it's true, maybe it's not true, what the research says. So I think it's a good thing for physicians. And I think it's a good thing for women, right? Because the number one reason that women will refuse hormone replacement therapy is breast cancer. And I hear it and I see it, and that's the main concern. And not just of women, of some doctors that are being approached to get a prescription of hormone replacement therapy.
Give me two scenarios of one person who you're like, she's slam dunk hormone therapy, and another patient who you're like, yeah, I'm not sure that hormone therapy is right for you. Give me the two scenarios so people can kind of know before they get into their doctor's office kind of what questions to ask.
So definitely the patient, and I like to say that there's three almost universal symptoms that I see very early in perimenopause. Sleep deprivation, and it's more the maintaining sleep, the waking up at 3 a.m. in the morning with not knowing why. Changes in their cycle. And it doesn't have to be a drastic change. It doesn't have like you miss your period for 3 months, then it came a month, and no, it doesn't have to be that obvious. But even changes in the length of the cycle, I think those are the earliest changes, or maybe in the flow of your period is also changes. So something that is outside the normal. And then night sweats. And this is not the patient that has to change their clothes in the middle of the night. Yes, it can happen. I've seen it in patients, but it's more like, oh, you wake up feeling hot, you turn the AC, it's just something different, right? So if it's decreasing your quality of life because of sleep and there are no contraindications, you're leaving my office with hormones, right? A woman doesn't have to convince me. If your sleep is already deprived, you're leaving my office with hormones. And yes, there's other things happening in your life that might be disrupting your sleep, maybe emotional stress, stress at work, right? I also take into account that too. But I would say 8 out of 10 times, it's going to be perimenopause that is disrupting your sleep. And if we have a variable that we can kind of control, we should. And maybe I have the patient that may have weight gain, right? I may have the patient that is complaining of maybe low libido, heat intolerance, joint pain, and maybe also trouble sleeping. But I see significant weight gain or high percentage body fat or high visceral fat that I question, well, maybe the symptoms are due to one, maybe the symptoms are due to the other one. In that case, I may start with a GLP-1 and see what symptoms improve. Now, this will be like the young 40-year-old woman, right? But if this patient is 49, I know by age they're 99% probably in perimenopause.
Do you check labs?
To diagnose, no. I go more symptoms because, in perimenopause, your hormones are going to be doing this. So today I check them and your estrogen is going to be perfect. Tomorrow it's going to be high. The next day it's going to be low. We would have to draw blood every single day to see where the pattern is. And we're not going to do that. And unfortunately, in saliva and in urine, there's not the best way to measure hormones. So it's not like we can tell a woman to follow it a month. It's only in plasma that we can really see true values of estradiol.
And I see this all the time. Like, I completely agree with you, but I see people in my community, also hormone therapy clinics and all this, they're checking hormones all the time. And it's hard to convince patients that they don't necessarily need those testing. There might be other testing that you want to do, to rule out other things, but you don't necessarily need
100%.
the hormones. So what about that person who, what comes first, GLP or hormone therapy?
Depending of their symptoms. If my patient is not sleeping or having night sweats, they most likely will live with both,
Mhm.
right? I get a gauge of the patient. Some patients are very sensitive to medications and they tell you, oh no, I need very low doses because I'm very sensitive. Then I'm going to start with one treatment. And if
Mhm.
it's the perimenopausal symptoms are disrupting their quality of life, I'm going to start with that. But if I have a patient that it's okay with medications that don't necessarily report to be very sensitive to doses and new medications, I may start both of them, a GLP-1 and hormone replacement therapy. And in some cases, like the patient that I mentioned, that I have a doubt if it's the obesity that is giving her some symptoms, or is it the hormones, I may start the GLP-1 first, and in the follow-up visit, I can get a better assessment of what's happening hormonally, and I may put her on hormones too. I don't gatekeep medications to my patients, but I wanna tailor it to their individual case, right?
Okay, switching gears a little bit. You get pushback on social media about your views and how, and I'm not singling you out. I'm just saying in general, people do.
In general.
I know that, you are pretty good about going out there and being bold with your thoughts. And so tell me a little bit more about that. What do people say and what do you say back to this?
I think, and my mother said this when I was little, you're too honest. She would always tell me, you tell things like that. You don't prepare me for the things that you're gonna say. And I'm like, well, I don't want to waste your time, mom. This is what it is. Uh, and I feel the same in social media, right? I think I don't like to beat around the bush, and I feel very comfortable with some of the knowledge that I have and I can give an opinion on. I feel like I'm professionally prepared, and this is not to be
No,
uh,
it's
con-
great. Yeah.
conceited or I don't know the other word, but or having a big ego. No,
Yeah.
I mean this is what I do every day. This is what I train for. I wrote a book on it, right? So I feel comfortable to debunk a lot of the misinformation that is in social media because I have the knowledge and the science to back it up. That makes me feel comfortable. And in regards to my personal life, I feel like the social media is lacking authenticity, right? Nobody is perfect 24 hours a day. Nobody is going to have a perfect life. Nobody's going to be smiling and agreeing to everything that you say, right? I feel like what I find in my social media, people respond a lot to my own personal life post, right? Or the way that I direct things. They're very direct. They really like that they don't make them guessing and don't they're not playing with their intelligence and like clickbait. What you see is really what you get.
I love
And
it.
I feel people need that. They need to see real people. I'm not perfect. I mess up. I screw up sometimes, and
So
it's okay.
tell us, when I was reading your bio, I read you are an immigrant from Mexico. I knew you were an immigrant. I know we've met before. I think you've mentioned it, but tell us a little bit more about your background. What brought you here? What made you, how did this happen?
I know. So I was born and raised in Mexico in a border town, Ciudad Juarez. So I grew up with a little bit of both cultures, right? Because it was a border with
Yeah.
El Paso, Texas. But I always said I had like the best of two worlds. I had
Oh.
my Mexican traditions, but I also have like the American view also. Growing up, I always grew up knowing that I wanted to be a doctor, but I also grew up like almost infatuated with New York. It was in the movies. It was this big city where I am. It's a small town. It's flat. There's no tall buildings. So I always thought one day I'm going to live in New York. I finished medical school and I decided to do my boards. I finished medical school in Mexico. So I decided to study for my USMLE, my American boards. So I took a course in Kaplan here in New York and I came
Oh,
with a
I
round trip
remember
ticket.
Kaplan.
I said, I'm going to go 3 weeks to New York. And I swear to you, within a week, I called my mom and I said, I'm not going back. I'm staying here. And she came like 2 days later. She said, something is wrong with you. And she stayed with me and she understood and she
How
left.
did
So
you,
I
I
never
mean,
went back.
where did you stay? How did you even,
Oh, so I came with a tourist visa,
yeah.
And then I started looking for a job to support my dream of staying in New York City because my dad used to sell used cars. My
Hmm.
mom didn't work.
Hmm.
So it's not like my parents put an apartment in me and gave me everything.
Yeah.
Nothing. And I always felt it's my choice to come and live here. It's going to be my responsibility to try to make it here, right? And
Hmm.
I cannot ask my parents with a Mexican salary of selling used cars to support my life in the big city.
Yeah.
So I work under the table.
Yeah.
I work as a hostess in Sushi Samba. I worked answering phones, being a doctor in Mexico, but I always saw it as a ways to an end. And then eventually I got an H-1B visa working as a medical assistant for a dermatologist. So that allowed me to rent an apartment, study for my boards. It took me 3 years working as a medical assistant to pass all my boards. Then finally, I had my certificate. I applied for residency and I said, I'm only applying to New York. And I ended up in the Bronx and Albert Einstein
Oh,
for
yeah. I went
residency.
to med school at Albert Einstein. I know it well. Yeah.
You know it well.
Yeah.
And then my fellowship, I didn't get accepted anywhere because I also not only applied to New York, and then suddenly there was one left opening position in University of Maryland, and I got an email. I applied, I interviewed, and I got it. So it took me
Beautiful.
14 years to really from when I left home to when I started working as an attending,
So
right?
there was a few years in there that you kind of, so you were like an older resident or fellow or whatever it was. Although you
I
probably
was in
saved
my first year.
you
I
probably
turned
saved a few
30.
years, right? Because I think it's not as long. Although no, you did your residency here, so yeah, it would be the
So
same
I did
amount.
3 years of internal medicine
Yeah.
and then I did 3 years of fellowship. And then I had a J1 visa. So I had to work 3 years in underserved area.
Okay. Yes.
So I did that. I did
Where did
that.
you do that?
And then I did it in Melbourne Beach, which is like 40 minutes from Orlando in
Cool.
Florida.
Amazing.
I went away. I said, I cannot be in the Bronx and Baltimore. I need a break. So I
Love
went
that.
to like an old like snowbird town and it was like really nice and relaxing.
I love
And then
that.
I came back to New York.
What a journey. So I trained in New York and Boston, and I lived in the city while I was doing my fellowship. And my husband's also a physician, and he was like, no, this is like two kids in a Manhattan apartment. And we were like, my mom was staying with us because, there's no maternity leave, and we had two little kids. And so I know the beauty and the struggles of New York very well. So it's really cool that you ended up in the city that you always wanted to. And what an amazing story. So you must have lots of feelings about the H-1B visa
Oh,
issue that's happening right now. I know a lot of my colleagues and people that family members, frankly, that come from India, for example, that's like the largest population of H-1B visa.
yeah.
It's a really big change and struggle for a lot of those people.
Yeah, I wouldn't be here with those new policies. I wouldn't be able to be here, right? I had a J1 visa, which is also stopped, and then I transferred to an H1 visa, so I wouldn't be able to be where I am. And I feel like I opened my practice here in the city. I have like 8 employees. I mean, I've created jobs here too, right? So, and
Yeah.
and I feel like I've helped people with my profession and my passion about medicine. So it would have been a shame.
Yeah, it's a really inspiring story to, come from a small town, like you said, in another country, especially Mexico, because I think, I don't know if you feel this and you can be honest, like, did you feel, were there any roadblocks for you as you were going through your journey because of your background?
100%. When I started my first year of residency, I approached the program director of Albert Einstein of Endocrinology, and I said, "Okay, I'm an intern here, but my goal is to be an endocrinologist. Tell me what I need to do to get an interview for endocrinology." He said, "You're not going to get it. You have 3 strikes against you. You are a foreign graduate. You have visa issues, and you don't have any papers published." That was it. That was it. Right. So I was like, okay, then I said, I cannot work on my visa. I cannot work that I'm a foreign graduate. I can work on my research. So I started doing research papers and all of that. But at the end, it was not enough. It was not enough. And I didn't get it. But you know what? I ended up 1 year in Johns Hopkins for my fellowship. So,
Amazing.
one door closes and
Yes.
a bigger one may open. So you just have to keep believing in you and keep believing that you have something to give.
So motivational. Okay, tell us about your book. Like, is this your first book?
This is my first
Yes,
book,
great.
and I'm so excited. I've been wanting to write a book for a bit, but the timing was not the right one.
Yeah, that's my
And
next question. After you finish your book, I want to hear about like how you're doing all the things because that's more of a personal interest question. Anyways,
Yeah, so the reason that I wrote this book is for two reasons. One is because what I learned from my patients with obesity, I felt that everybody needed to hear it. Doctors and people that have somebody who knows has obesity or they struggle with obesity. I wanted my book to be a validation for their struggles and for the gaslighting from healthcare, right? Because we always tell patients eat less, exercise more, come back, do it harder, eat even less, exercise more, come back. And then what we said, patient is not doing what we're telling them. If I went to their house, I'm sure they were not eating and what they're telling me they're eating. If they wanted to lose weight, they could have lost weight. That's how we used to think, and many doctors still think, right? But to learn what obesity is and to learn that there's something called transgenerational obesity, that it can come from the grandparents, that 40-50% of the reason somebody has obesity may have nothing to do with them. It was already predetermined by epigenetics, right? Then we add hormonal issues, and then we have industrialization. We live in very industrialized worlds. Food industry, that's another part of industrialization, that they're made to be hyper palatable food that create a reward system. So when you learn all of that, you can understand. And when you have patients coming and telling you, I've been doing it for 20 years, from 30 years, teaching me about diets that I never heard, I was wrong. We were wrong. Patients were actually following our recommendations, but that was not the problem, that was not the solution. So that was the first time that I thought of doing a book. And then second is by seeing how much misuse of this drug, the damage that it can cause, that patients are not getting the results that they need. Because when we talk about weight loss, we're talking about body recomposition. That's what we're talking about. Decreasing your visceral fat, decreasing your percentage body fat, and trying to increase your muscle mass. That's what metabolic health looks like. Not you losing 50 pounds and I don't know if you lost 15 of muscle. No, we're moving away from that, right? So this is to close that gap between the educated provider and the speed that these medications are being developed, because the science is moving too fast, but faster than we're training doctors to serve in a good way to patients, right? So that's why I wrote my book too, is because it's closing that gap, because not a lot of people have access to me as a physician, and even if they did, it's just one of me.
Yeah.
So this is an extension of me. This is my clinical experience for more than 15 years with patients with obesity, and I guide them really like hold their hand through the journey. And the other reason that I wrote my book is because what I'm seeing that we never saw before, for the first time, we're having masses of people reach a goal weight that was never possible before, right? What I'm learning now is by following my patients long term is that once they get to the goal, it doesn't end there. The psychological changes that happen with weight loss, some patients for the first time, they're seeing themselves in that weight. For some patients, their spouse never seen them in that weight, right? For some patients, they don't know how to handle people being nicer to them because they're in a different weight. We're not giving patients the tools of what happens even just beyond the physical weight loss. There's social changes, personal changes, psychological changes, cultural changes that we need to also, to be fair to our patients, we need to keep the tools to how to approach this new world when they're in a new weight. That for some patients, it may be a very drastic change.
Question that came up for me while you were talking is there's a lot of talk about microdosing. Do you talk about that in your book or on your
I
podcast,
do. I do
social
talk
media?
on in my book about microdosing. I think microdosing really is going to have a very big use in the maintenance of the weight loss, right? When patients, we can decrease the dose. And for some patients, we can even decrease further than the available lowest dose that we have, especially on tirzepatide, which is stronger. So I really think that we're going to see use of microdosing there. For or for longevity, there is room, right? But most of the results that we're seeing in improvements of GLP-1s are due to weight loss or improvement of glucose, right? Which are
Hmm.
those two of the main drivers of disease, hyperglycemia and visceral fat. So we know that by reducing those two, we're already improving the long term health of somebody or decreasing the risk of other chronic diseases that may come with it.
Yes.
Because I can argue that if somebody says, I am healthy, I don't need to lose weight, I just want the anti inflammatory benefits of a GLP-1, I just want the extra
Yes.
protection, I would say, look at your body composition. If your body composition shows true metabolic health, meaning you have more muscle than body fat, you have low visceral fat, most likely you're getting all the benefits that you may think you're missing out from a GLP-1. Because muscle mass is our best anti-inflammatory organ. It produces hormones, which are called myokines. They regulate glucose, they're anti-inflammatory, decreases insulin resistance. So if you have high muscle mass, you have all that going for you. And if you don't have visceral fat or high visceral fat, you also don't have inflammation. So a lot of the benefits that you may think you're going to get, you're already getting from having that body composition. But the other option would be somebody who thinks they don't need to lose weight and they said, I just want the extra benefits. Many times we put them in a body composition and surprise, surprise, you can lose 15 pounds. And that's what you're going to feel improvement of being on a GLP-1. So it's going to be interesting to see healthy individuals with a healthy body composition, giving them GLP-1. What is it that we're seeing?
Yeah, that's interesting. In that sense, I mean, pretty much like a huge number of the population would benefit from GLP-1s if you're looking at it that from that lens.
Exactly. If we're looking at our body compositions, yes.
What about the new ones coming out, the new generations?
So I like to people to visualize them like the iPhone, right? When liraglutide came out, Saxenda Victoza, that's the iPhone 8.
Yeah.
Then Ozempic came out, that's the iPhone 12,
Yeah.
updated, better, more effective. And then came the iPhone 16, which is tirzepatide, more effective, less side effects, and the next iPhones are coming up. So they're just getting more sophisticated, this class of drugs. What we have next that we should be very excited is retatrutide, which is a triple agonist, GLP, GIP, and glucagon, and up to 40% total body weight loss. So it's like Ozempic on steroids. So that's going to be our most potent drug that we're going to have. And that probably is going to come out by Eli Lilly by end of 2026 or beginning of 2027. Then we have the oral version of semaglutide, which we currently have as Rybelsus, but at the doses that we have, which is 3 milligrams, 7 milligram, and 14 milligram, we don't see significant weight loss comparable to the injectable semaglutide. But they're coming and probably end of 2025, next month, with a 25 milligram dose. So 3 times of what we have right now. And what is interesting to see is that the side effects from 25 milligram compared to the 14 milligram, it's not too different. Also, semaglutide injectable, which our max dose is 2.4 for weight loss as Wegovy, is coming in the 7.2 milligram dose. And there we're seeing comparable weight loss, comparable as tirzepatide. So at least we have more options, right? So if we have a patient that max on 15 milligrams of tirzepatide and we're not reaching any more weight loss, then maybe we can flip them to semaglutide 7.2 milligram and see how if they respond more. And then also in the works is a monthly injection, Maritide, which is a GLP-1 that will be a monthly injection. I think that's going to be a great option for weight loss maintenance, right? That you move
Yes.
yourself from a weekly injection to a monthly injection, or maybe the monthly injection will be good for adolescents that don't want to inject themselves every week.
Mm.
I think the oral versions of GLP-1 are also going to be very useful in adolescents that don't want to know about a needle. So I think it's just going to broaden the options that we have for more people to use these medications.
So give me your prediction. Do you think that in 10 years, a majority of people, including adolescents, will be on GLP-1 medications?
Yes, and I predict that in the next 2 generations, type 2 diabetes is going to decrease. We're going to have less incidence of certain cancers that are associated with obesity, such as postmenopausal breast cancer, colon cancer, prostate, thyroid, pancreas. I predict that we're going to have less chronic diseases, that specialties that were built around the chronic complications of obesity are going to disappear, and we're going to be pretty much focused at the prevention part with a GLP-1. Again, that's probably not going to happen in 10 years, but maybe in the next two
Next
generations,
generations.
right? We will see that.
That's such a crazy thought, honestly, like to think like, students and adults that don't look like, that may not look like the typical obese person. I have a very strong family history of type 2 diabetes, and my father's side, like every single, like all five brothers have diabetes. Their dad, it's a very, very genetic. And so even for someone like me who's very small, I always tend to have higher blood sugars. And so it's really interesting for me to kind of follow as we kind of go through, because my dad was very thin when he was diagnosed with type 2 diabetes. It's like looks very thin, and now over the years he started on a GLP-1 medication. I will tell you, one of the struggles I think a lot of people have, including himself, and is insurance coverage. So how do you deal with patients who, one, either are struggling to get it covered, or two, don't get it covered? Because it's very expensive
So
still.
it is a currently nobody should be paying out of pocket
Hmm.
$1,200 for the medication.
Yeah.
Absolutely nobody should be paying that. One, if you have a commercial insurance and it was not approved or they don't want to cover it, they both pharmaceuticals who have right now the two main GLP-1s that we have available have manufacturing coupons that will cost the cost to half, right? So still expensive for many people, $500 or $600 a month. But then Eli Lilly has tirzepatide in a vial from their direct pharmacy that for the initial dose is $299 and then higher doses is $499. Now, the tirzepatide vial, now we can start to get more creative because we can manipulate it, right?
Yeah.
I prescribe some of my patients the 15 milligram vial, but they're on 7.5 milligram. So that's going to last them 2 months for $499. Or you can give them, if they're on 5 milligram and you prescribe the 15 milligram, then that's going to last them 3 months for $499. But of course, you have to be very sure that your patient is not going to overdose themselves, right? So you need very proper training in them to see and show them really how it is. So also with the announcement of last week from the government that they're going to decrease the price of GLP-1, I think that's also great. It seems like oral medications will be at $150 per month, which that is huge because If
Yeah.
to think right now, one thing that oral medication is going to be cheaper, Rybelsus is same price as the injectable Ozempic, right?
Wow.
So it's not like just because it's a pill, it's cheaper, but giving the deal that they reached that Eli Lilly is going to sell orforglipron, their own oral GLP-1 at $150 a month, that's also going to be huge. And
Huge.
also Medicare and Medicaid are going to start covering the medication. So I think that the accessibility is becoming more and more less of a reason of not being on a GLP-1 medication.
Okay. And I mean, we could talk about this all day, but I have a couple more questions. All these people, I myself have seen in the last year a million different online pharmacies and healthcare providers or healthcare
Telehealth, yeah.
telehealth where you can just get your GLP-1s. How do you feel about that? It's like compounded GLP-1s, et cetera.
So in my book, I talk about red flags of how to pick a good telehealth platform, right? How to know. To begin, if they're not doing a body composition, if they're not guiding you how to get a body composition, I send my patients a home in body scale so they can monitor and I can see their results every appointment, right? Then that's a red flag. If they're not talking to you about muscle or how much protein you need to eat to prevent muscle loss, bone loss, hair loss, that's a red flag. So I do feel that we're going to need the ancillary support of telehealth because the amount of patients with obesity to the amount of trained doctors that we have or is
Yeah.
huge mismatch, right? So the more the merrier. I would say just do it responsibly, prescribe this medication responsibly, because any specialty has always an encounter with a patient with obesity. So any of those encounters is a missed opportunity, right? And most likely they're seeing that patient because of the complications of obesity. So I feel like every specialty is going to have this conversation and potentially offer treatment to the patient, right? But we need trained doctors to feel comfortable because we doctors don't like to prescribe what we don't know, and
Yeah.
sure, and rightfully so. So to get some courses of the Obesity Society Medicine, Obesity Medical Association, they always have virtual courses so people can get educated. And patients, and that's also why I wrote my book. I say with my book, I hope that even though there's not enough educated doctors, we're gonna have enough educated consumers so they know how to manage it, even if their doctor doesn't know how to guide them.
I love that. First of all, thank you so much for coming on. This is a really important conversation, really important topic, a really important book. And so I'm really grateful for your time and expertise on this. I think people are going to find a lot of value in this. So, can you tell us all where we can find you, where we can find the book, where we can learn more, etc.?
Yeah. So my Instagram handle, which is where I'm more active there, is Dr. Salas-Whalen. And my book, they can find it in weightlessthebook.com. And there it tells you how to pre-order and you can read the introduction of my book in the website of the book. And also if you do a pre-order, you can get the first chapter too. So you can start reading and get excited about the book. And it's almost 6 weeks that it comes out.
Yes, so exciting. Are you going to do a book tour or are you?
Yes, I'm going to do a book tour in January, February, probably.
That will be so fun. I hope to see you on your travels or when I come to New York and around
Definitely.
around that. So I want to thank you for coming on. So it's Weightless the book.
The website is weightlessthebook.com.
Perfect. And so, any parting words, anything you'd like to share with the audience before you go? I'm really, really excited for the world to get this and excited to have you on, later on this year, next
I
year.
would say have empathy with people with obesity. Think differently when you see a patient with obesity because we are predisposed to think that they're lazy, that they're not smart. If they wanted to lose it, they already lost it. I mean, I've been humbled by my patients, and I wish everybody can understand their stories and their struggles and all the effort that most patients put on, and not to shame them, right? Because patients have been shamed from gaining weight, from their mom, their pediatrician. They've been shamed for not losing the weight, and now they're being shamed for accepting treatment in a medication. So I would say have empathy for somebody who has obesity.
Oh, I love that. Thank you so much, Dr. Salas-Whalen, for being on. And I want everyone to go check out her book, waitlistthebook.com, and everywhere books are sold, correct?
Yes,
All
everywhere.
right. Thank you. And thanks everyone for listening. I think this is a super important conversation. I hope that you'll share this with your family and friends so that they can get more educated around these medications, which are here to stay.